Please go ahead.
Okay. So we have a 63-year-old male who presented with an inferior wall MI, and the culprit lesion at that time was the right coronary artery, which you'll see has been treated with an angioplasty and a longish stent right from its mid-distal segment to the proximal ostial area. This was done in September, and at that time they found left coronary artery disease with a syntax score of 19, creatinine normal, good LV function, and these are the images. So this is the angiogram done today. You want to show them the right coronary artery first? So this is the right coronary artery. The stents look patent. So we went and did the angio for the left. So the angio to the left, go to the RAO. Stop over there if you can. So in the left coronary angiogram, the lesion at question was that distal left main, which is just before the bifurcation, and it kind of wants to kiss the ostium of the circumflex. There is a little eccentric plaque in the proximal circumflex, and then there is what looks like a moderate stenosis in that horizontal part of the circumflex before it curves into those 3 OM branches, the top one, the second one, and the third. Now, the other one is, go to the next view, please, the LAD, cranial. So here we have this little less opaque lesion at the level of that diagonal branch in the proximal LAD, and then follows the septal branch, and then you have a very insignificant plaque in that mid-distal LAD area. But our question was, how do we address this coronary angiography with respect to the angioplasty done to the RCA with the patent stent now? Is there any ideas? Does anybody in the audience think that we should just consider this left main to be significant and not worry about any imaging or physiological assessment?
Hi, Kirti, this is Nick Parchura here.
Hi, Nick.
Adjudication of the lesion of left main cannot be based on angiography alone.
Excellent.
That's very clear, simple and straightforward.
Okay.
It's wrong in 50% of the times. Ostium or bifurcation. It has, in my opinion, in this case, I would use an IVS run both from LAD back into left main and circ back into left main. And then I would talk about it, whether it is significant or not significant, which lesion, what lesion.
So would you base it on physiology or would you base it on imaging?
Right. You can, in this case, we can say that it's a moderate lesion of the left main bifurcation. We don't have the full data at the moment with us. So in many cases, I combine both.
Yeah, sure. So I think that's what Kirti has in mind. So Kirti, tell us what you plan to do. Did you get the physiology in, or did you go for imaging first?
So I think what I would do in my own lab at home would be I do a physiology first.
Yeah.
So that's what I did. And we started with, so we really wanted to understand the complexity or the scope of the problem. And the first thing I started with was to go into the worst branch of the OM and take a physiological assessment of the circumflex artery. And so can we show them the RFR for the circumflex OM, please? So this is the RFR value for the circumflex with the branch. Keep that stationary, please. Stop that image. Into the upper OM branch. So right in the upper OM branch, the RFR value of 0.9.
So with IFR, RFR, FFR all being continuous variables, how would you really judge a 0.90 RFR?
Excellent question. So what we did was we went one more step. Now show them the FFR. We gave adenosine and challenged it.
Yeah, sure.
.82 for you.
Can you see those? You're back to gray zones.
No, I don't know whether this is a gray zone. For me, this is white enough to say I don't need to touch this area.
Javier,
No, I think it's a very nice demonstration that when you have something that is intermediate in one technique, you find typically that.
Would you like to combine an imaging here with an FFR of 0.82 and an RFR of 0.90? Would you like to do an imaging before you leave this well alone?
Well, I mean, first of all, I personally will not use IFR. I will even say rely less in RFR because it is we still have only data coming from the bench, and I will do what they have done, that is rely on FFR. So 0.82. Can you remind us about the age of the patient?
63.
63. I will take it for significant. I mean, I'm not going to leave a left main with a 0.82.
So Javier would say that this is significant.
Of course. I mean, if in a 62-year-old patient.
So we did a pullback.
I think that any of us will consider that this has not the same meaning than in a patient that is 90 years old.
That's the point I was trying to make.
So we did a pullback, and now this is the pullback, and this is when we cross and come back, and this is the reflection of the left main from the circumflex, almost nothing. So the tightest lesion is in that proximal mid-segment of the circumflex rather than the ostium of the circumflex. So we went and did an LAD FFR after that. So let's show them the RFR of the LAD.
What is the significance of distal left main if there are downstream significant lesions like LAD and L6?
So Kirti, the question which has been asked is if there's a downstream lesion of the circumflex or LAD, what would be the significance of assessing the proximal LAD on an FFR or IFR?
Distal left main.
So this is the RFR. This is the RFR value. Can you see that 0.78 of the LAD? And the FFR value of the LAD
0.65.
So where's the FFR value of the LAD? We're just trying to get it for you.
77.
It was 0.86. This is the FFR value, and the RFR value was 0.86.
If the combined value of LMC and LAD is more than between 0.65 and between 0.8, you have to go for an imaging. That is the recommendation.
Excellent. So first of all, does everybody in the audience believe that based on this functional lesion, functional assessment, it might be okay to treat the left main LAD segment based on imaging, but it might be a good idea to leave the circumflex alone?
Javier felt otherwise. He felt that the circumflex needed to be treated as well.
Well, no, I was referring more to the
left main.
Left main,
waiting
yes.
to see the whole study
Based
completed.
on an FFR on a circumflex, I would not want to get into a complex angioplasty here unless the FFR was
So we can
significantly
treat the left
positive.
main LAD and come back and review the circumflex after having treated the left main LAD and see what the physiological significance.
Excellent. So let's go back to imaging. So most of you believe that we should put in an imaging catheter into the LAD and take a pullback, right?
And both circumflex as well, please.
So I really,
Yeah, that's provocative and sure.
I would love to do that. But my question is that in these kind of angulated lesions, you put in a IVUS catheter, and if I raise a plaque and make it hazy, then I'm pushed into treating it. So let me show you what I got in the LAD, and then we can figure it out.
Yeah.
Can you please show us the LAD pullback? Just run the whole pullback. So this is a pullback starting in from the the distal lesion wasn't too bad, so we will save time. Why don't you come down and save the distal lesion and just show them start from from here. This is a decent artery with minimal atherosclerosis. This is the intervening segment between the septal and that distal lesion, and we're taking a pullback. Can you guys see the pullback?
Yeah.
Okay.
It's kind of not.
The artery looks like around 2.5 over here to 2.6. And then you have that bend where the images are skewed a little bit because of the wire bias. That's where we're coming into that proximal lesion now. You can see that eccentric plaque, the septal branch. And a rather fibrocalcific lesion here. Now this is the proximal to the lesion, and you can see that this entire extent, which looks okay angiographically, I didn't think that there was a decent landing zone up until this point here, but that decent landing zone did not extend for more than 3 to 5 millimeters, and it came into the left main.
Yep.
And look at the left main. We are entering the left main, which is significantly plaqued, and we'll show you two areas. Our minimal luminal area in the left main is 3.58 millimeters square. So, Dr. Hirohata,
Yes.
why don't you tell us more about what
Yeah.
you think about the...
Yeah, actually, according to this IVAS finding, distal part vessel diameter of the distal region is very small, so there is no problem for touching. There is no problem and do not touch the distal part. But problem the proximal LAD, and proximal LAD around the first diagonal branch should be the very significant stenosis according to the FFR finding and OCT as well. And according to this angiogram, proximal LAD region looks like a very simple region, short region, maybe the stented segment of about 12 or 15. But according to this IVAS, proximal reference part for the proximal LAD seems to be a little bit difficult because of the larger amount of plaque burden. And plaque is extending just proximal of the region and distal left main. So I think it may be difficult to put the short stent only proximal LAD for this region. So I think my idea is put the stent for left main to LAD for probably the longer stent, or put the short stent for left main to proximal LAD and another stent for the more distal part. Diameter of the left main is very huge.
So 2-3 issues. Would you like to prepare this lesion with either a cutting balloon?
Show me the
How much is the...
Yes. So I want to, Nikhil made a point that I should put the imaging catheter in the circumflex artery. Now I want to show you the circumflex.
We saw the
origin.
circosteum.
See, look at the circosteum here.
Yeah.
Yep.
My impression, and if I look at my, what I think, I could be wrong here, that most of the plaque is away from the carina and it's on the other side, like it is in most cases. And I would be happy to maybe place a wire, but I think I would leave the circumflex alone and not touch it. And if required, once we put a stent, we can do an FFR on the circumflex to see if we've done something.
But as a purist, the point which Nick had made was
I think
to
very
be
valid.
appreciated, that
Very
the
valid.
tangential view of the circumflex ostium can sometimes mislead us, and that's a point we have seen in daily practice many times. So, but here the circosteum does look very good and very roomy.
Dr. Hirohata, what would you want us to do an IVUS on the circumflex?
For circumflex, I think it depends on cases.
Yeah.
If you want to see the detailed image of the ostium of the circumflex, you had better to intravascular ultrasound from circumflex to left main. But in this case, my
in this
feeling
case-
is not mandatory.
Yeah.
Of course, if you want to see further information, you had better to do the intravascular ultrasound from circumflex to circumflex to left main. But I think that it should be okay if only
been
putting a wire for the circumflex.
How many people would put a wire into the circumflex?
We have about 25-30%, I think, or a little more.
So I would not put a wire in
How
the
many will
circumflex
not
at
put a
all?
wire in the circumflex?
Okay, give me
I
a
think
cutting
that's
balloon.
again, so we have a divided house here.
Anil, it's very simple.
50-50.
If you believe that the circumflex ostium is not important, there's no question of putting a wire through it.
Yeah, that's right. So that's why I raised my hand. Thank you.
I can
3 by 6.
input due to the distal left
2.75 by 6 then. Oh, give me 3 or 10, that's okay. 3 or 10 is okay.
Gives an indirect clue that in some studies, if they just interrogate the distal left main, if it's less than 6.1, then the likelihood of a LCX compromise is higher. If you don't want to put a catheter into the LCX, personally, I would put a pullback from the circ to the left main as well.
Yeah. Okay. So Again, you have the left main. You had visualized the MLA was how much for the left main?
Okay, can you see that? MLA image?
3.58.
3.58. So, which is definitely significant for left main. But looking at the circosteum, one can possibly say that one may get away without putting a wire there.
My problem is, circumflex ostium visualization on IVUS by putting a catheter when there is a right angle bend is not easy because the catheter never crosses the ostium in a transection. It's always an oblique view.
Always biased.
So you are not going to get the best MLA. And I think when you don't see so much plaque, I'm going to try and keep it simple and do what I would do in my daily practice. And I would keep it very simple over here. So
what is your plan?
So how are you preparing the lesion?
So I like to put in a cutting balloon if I can, likely to not slip, and then go and dilate this lesion gently to complete expansion. I see a little bit of calcium across the lesion, but nothing really significant. We've got a 3010. I would have preferred a 306, but we don't have a 306 on shelf. So I think a 3010 is good enough. And let's start from here. Can I have a little bit of a test, please?
Yeah.
Come back a little bit. Yeah, okay, there. Go up to 2.
So any particular choice of scoring balloons? You're using a Flextome or you're using?
I'm using a Flextome.
Yeah.
3, 4, 5. Have you de-aired it? There's air in the.
There's
can we
lots of
just
air.
de-air it? Yeah, lots of air. So just make sure it's de-aired properly. Just once more, de-air it. Let it. Okay, good. Go ahead. 2, 3. Anybody would do anything different for?
Any other choice of scoring balloon, or somebody would use a non-compliant balloon? How many people would like to use a non-compliant balloon?
NC balloon is
yeah.
simply possible in this case.
Yeah, it's.
I don't think it's severe calcium.
Down.
You can have a nearly 20-30 degree arc in one or two areas where you can just tackle with an NC balloon.
NC balloon.
Okay, come on.
So
come
about
to
30%, 40% people believe that a non-compliant balloon would have done the trick. In most of the labs, we would be using an Oxford balloon. So
as I told you, Anil, I'm doing exactly what I do at home.
I know that.
I'll do what I do for my patient in my lab, and each one will have his own preferences always. Is this the contrast? Yeah, okay, great. Okay, come on and give me a 2. 3, 4, 5, 6, 7, 8, 9, 10. Give me epicranial. Go, keep it on. Hold it. Epicranial. So it's a great idea to just check whether your balloons have expanded in at least 2 views in these kind of lesions. And you can see there's pressure drop. Go down, down.
So Vijay is asking, why do you want to go so slowly in inflating a Flextome in the left main?
Because all these lesions are best very gently dilated.
So
when you try to go very rapidly,
well.
when I dilate them rapidly, sometimes I've seen perforations, and there's a sudden give way, and I don't like that. Typically, I am slow on inflating these and very gently to higher pressures. So we had decided that we were going to use the MLA, the luminal size in the left main at the landing zone was 3.5. So we're going to use a 3.5 resolute integrity and the distal landing zone in the LED was 2.5 millimeters. So Dr. Hirahata, would you agree that we should use 2 stents rather than 1 to cover this lesion?
Yeah, actually, this is a very long region, and if you and the distal reference segment is about 2.5 millimeter, so it's going to be too small for the maximum dilatable diameter for the left main stenting. So I would like to say that 2 stents is better for this case.
Great. So 3.5.
2.5 and 3.5?
3.5, 15 should be a good start, or 18. Give me an 18. Yeah, 18.
So you're planning to first do the left main and then come back and do the distal LED?
Yes.
All right. Now, many people would do it differently. They would do distal LED first and come back and do the left main.
Yes.
So tell us your reasons. I know you do this, and I also incorporate it in my practice a fair bit. So I would like you to tell the audience why you want to do the left main first and then go through that stent and do the distal LED.
I think one of the biggest reasons is that if you choose your landing zone proximally and then work forward from there in the left main, then the one big thing that you can do is you can be more exacting in the amount of
more
stent
precise
and actually reduce your overlap segments to the minimum. That is one. Two, I'm a strong believer that small stents are best placed within large stents and not the other way around, especially at the overlap areas. And three, I think when you've dissected the left main, it's best to secure the left main in this kind of a situation, and then just it makes your life so much easier. This is a rather stable patient, but if
Great
you had
points.
someone who's
Anybody would have a differing point of view?
Yeah, I think the distal stent, smaller stent should be put first, because otherwise you will not be able to overlap the segment. If it is
well, you cannot define the exact length because you're choosing one reference point. Here you're using the proximal landing zone as your reference point, so then you can change the length of your distal stent. So here we have different points of view. Vijay, any differences? Dr. Seth, would you place the first stent proximally or first stent distally?
Wait, let me engage you.
So Ashok says obviously distally.
There's no argument for putting first stents in. The overlap on metal stents doesn't have to be defined, and therefore you can actually overlap to any extent. So I think it would be very foolish to put a proximal stent. You get stuck. There are numerous issues which happen. You can actually have wire getting stuck. You can have stents getting stuck.
In a 15 millimeter stent.
One of the major problems, I think I always put a first stent as a proximal stent. I will put first. Why I just do that? If you take a 15 or 18 millimeter stent and you have a distal stent is taken and the 15 millimeter, you're missing 1 millimeter away, then you have to
go back to that
third stent.
No, Kirti had given some very good arguments, and all the arguments are good. Balbir, would you like to comment whether would you like to do the proximal stent first or the distal? Balbir also wants. So let's take a show of hands. How many people would like to do the distal stent first? So we have about 75% people who would like to do the distal stent first. And how many would like to do a proximal stent first? So we are a minority, but all the same, it's okay. It's better to be a minority.
Well, Anil,
I think it is only 3 people.
Yeah, that's all right.
Well, Anil, both concepts are okay, but the proximal stent in this case I would put first, simply because in this case my landing zone millimeter to millimeter is more important to me.
Exactly.
So there's nothing wrong or right about it.
No, I agree. I agree, but thank you for saying this and not raising your hand. That defines your political rectitude sometimes.
You know, I'm sure everything is okay. I mean, there is no one way to skin a cat, right?
Yeah, there's no one way.
Yeah, so
what is the stent which you have selected?
A Resolute Onyx. And we had defined it when we did an IVUS in this view. We defined that our proximal part of the stent needed to be at this area right there.
Right,
yeah?
right.
So can you please, one little test, please?
So how many people would not cover the ostium of the left main at this point? Nishit, 1, 2, 3, 4. How many people would cover the ostium?
Just give me.
I think there's a huge majority. He's not covering the ostium.
I don't see enough disease on the ostium at all.
So your point is well accepted. It's just that.
Okay.
And choice of stents. Would you use any stent, or would you prefer a particular stent because of the expansion characteristics or the stent geometry?
So my favorite left main stent is somehow become the Resolute Onyx for a variety of reasons. But I'm sure it's like, everyone has his own pick, everyone has his own favorites. It's just, how do you defend it? There are many ways to defend that, but there could be counter arguments as well.
Yep.
10 atmospheres. Yep. Now, can I have the IVUS, please? See, one of the reasons is when it is so close to the guiding catheter, I like to use a continuous sinusoid design. It probably gives me the comfort of minimum, distortion of stent at that edge with the guiding catheter. But I don't know what the others have to say about it.
Anybody with any different choice of stent for the left main? I mean, would anybody have, or it doesn't matter? How many people think it doesn't matter which stent you choose as long as the diameter and the length is right? Can you raise your hands? So we do have, yeah, I know. And how many would still stick to something like an Onyx or a Synergy for a situation like this? Well, so
it's a majority.
It is a majority here.
Apart from the stent, design, he has taken a EBU catheter, and if you want to place it in the ostial location precisely, can we put in a floating wire so that there may not be any damage to the ostial strut, longitudinal deformation, and also we can take the.
Yeah, but he has to
maybe
do
a small tape, but.
Here it's not covering the ostium. Stent
If you want to cover it.
away. Yeah, it's not covering the
He's
ostium.
not covered the ostium. It was a long left main with a disease-free ostium.
So there are two things that decided my landing of this stent. One is that I needed to be in a plaque burden which is minimum. It doesn't necessarily have to be a normal looking artery. It has to be a plaque burden of less than 50%, right? With a good large to accommodate a 3.5 stent.
Do you think you should use a plaque burden of 50% even in the left main?
Dr. Hirohata, what do you think? What should be used?
Yeah, I think in case of left main, I think the fully coverage will be better, of course better. But in case of residual plaque with more than 50%, I put another stent. Okay, so so this is the second IVUS after the.
My problem is, for a very small advantage, we could extend this stent further, but if it came out of the struts, then recanalization of the left main can become a little of an issue.
Yeah, but the only point is that we choose an IVUS music criteria or whatever. We choose 50% plaque burden to 50% plaque burden in the rest of the coronary tree. But does the same rule apply to the left main as well? That is the point which we're
going to show you now. We're going to show you the edges, yeah? And tell me if that was okay. So this is the mid-LED. What I'm trying to see is landing zone distally and the edge of the stent. So I'll have a precise assessment of the length of the second stent I need. Yeah. So give me a landing zone there. Yeah. Bookmark it.
Yep. It's almost landing zone. Vessel size is not so huge. Probably
this is the dilated egg segment.
You can see some plaque for the upper side. And probably the diagonal branch is coming from here. Yeah, this is a diagonal branch. Yep. And you can see some fibrotic calcified plaque for the about 180 degrees. Vessel diameter is maybe around 3 millimeter around here. You can see some dissection for 6 o'clock. Yeah. For the proximal eccentric calcified plaque. And this
is the edge of the stent, so bookmark that.
And probably the circle is coming from, this one, 4 o'clock. And left main seems to be a little bit under expansion.
We could
So
go up on
you need to work
Yes.
harder on the left main.
Right.
Yes,
right.
we're going to take a 4-row balloon and expand it.
Yeah.
Give me a 4-row short balloon, please.
I'm
By
going
any
back to
means, when we are
proximal.
deploying any stent at left main, are we concerned about the radial strength of the stent?
What about the edge? What do you think about the edge?
Do you think that
Oh.
by
Four row?
changing the platform of the stent, does
Yeah.
it matter when we are deploying it at the left main?
Give me a 4-row short
So
balloon, please.
I have,
Yes,
Eight.
I mean, I have some personal views on this, but I don't think because I would rather that somebody else because I have seen some stents which have very low radial strength, and we feel that the middle portion of those stents look very
408.
costly, and they give you nightmares subsequently. But Dr. Seth, would you like to say?
Give me
which
the
is-
length of that
would the
second
radial
stent
strength matter?
that I require
Yeah.
from the 2 bookmarks.
Right.
More than the radial strength, the longitudinal foreshortening is
Length.
very important in left mains because
So
when
the
you do
concerns
the,
are not-
the
What is the length that you calculated? 22?
I think
22, 23. Yeah.
it does. At the end of the day,
4-0.
it does provide
Short
this
balloon.
bulky plaque calcification and other unfavorable features. Luckily, most of the present generation of stents have similar radial strength.
Can you
So
give
we're
3,000
not
units of
looking at
reference?
2.5 or
great differences,
2.25.
but we're certainly looking at great differences
3,000 units of
at
reference.
least in terms of long-term outcomes, which haven't been demonstrated for some of the newer generation of stents, and we extrapolating the results of some of the
Yeah,
gold
looking at
standard
2
stents. So I think it's a
2.5
big
centimeter
area
and
of discussion.
2.25 centimeter.
In general, use the stent you're most used to, but prepare the lesion well. I think that is the dogma most important, rather than just decide. on the
Especially since all these
radial
stents
strength.
today are 60 to 75 micron strut
Absolutely.
thickness, so
So they require greater
much better
of the
preparation.
bed.
2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
While he's inflating this, I just
Down.
wanted to point out, and I hope he did this, optimization of this stent which was put in the left main should have been prior to IVUS. There was no point doing an IVUS. You have
he
an
was trying to bookmark and define the
unopposed-
distal
Do I
stent.
do this?
Yeah, but that's
Go
sure.
up.
But you have to do that even after optimization.
He'll
We
probably
must-
do that again.
We must remember that these are unopposed struts in the left main.
He probably do
Biggest
that.
reason for stent distortion is these
Down.
under-deployed stents, and never do anything more than complete the job in the left main prior to doing anything else distally.
So a 27522 maybe? Or a 2522?
2.5 centimeter.
2.5.
2522. Must be the diagonal branch or so.
So from the bookmarked areas, the defined length was 20.
Can I have a spider? Well, let's
I
look at
think
the
20,
circumflex.
about 22
The ECG is
millimeter
okay.
for the residual length.
Blood pressure is okay.
what was the post dilatation balloon used and how much did you go?
We went up to a 4-row balloon and we did a 12 to 14 atmospheres dilatation and a pot.
Yeah, please,
please.
please, please.
So epicranial, please.
So we have Praveen.
One issue on the size of the stent that he is now choosing. 2.5 I think is small. Kirti, can you hear me? I don't know.
The landing zone on the IVUS.
Yeah, it's the distal landing
is
zone.
about 3 if I'm not
No,
wrong.
it was 2.5. It was measured. It looked angiographically.
It was certainly more than 2.5 if you go by the external elastic lamina. Include the media.
So we
And
don't
2.5 for a prox. This is also truly
22.
proximal LAD because the first stent is in the left main.
Yeah.
I am very clear that no proximal LAD should be less than 3. So yes. So I
In
think
any case,
that
he's
taking
using
that
an-
as a dictum. I think 2.5 is undersized. Well, we have just seen a snap. They know what is the real size. I still feel it is about 3.
So the nice thing is that you can take a 2.5 stent and expand
And you
it,
can make it into
make it 3, whatever.
3.2,
But-
3.3.
But my whole take on these kind of atherosclerotic lesions is that proximally you can be a little aggressive, but distally try to be a little gentle. You don't want a dissection spiraling down. You don't want to be subintimal over there at the edge of the stent. And with imaging there, you can always optimize it as we go along with a bigger size balloon. Go up. Take a picture. Yeah, go up, go up, go up, go up. This is perfect. This is 2, 3, 4, 5, 6. Down. Now come up, go 10, 12. So I just deployed it at a very low pressure and I'm got my balloon in and I'm going up to 10, 12. 12. Thanks, thank you. Down. Can I have a 3O balloon to dilate it
yes,
before I do an IVUS? Yeah.
I think there was some talk about the radial strength of the stents as you overexpand them. What I have seen in pen studies is that if you overexpand a stent, the usual belief is that if it's a 3.5 stent, you expand it to 4 or maybe a little over 4. The usual feeling is that the strength, the radial strength will decrease. In fact, it is to the contrary. As you overexpand the stent, that zigzag pattern becomes straight. It becomes more rigid. The radial strength of a stent increases as you overexpand it. However, since it is more rigid, it is more likely to wear and tear and fractures.
Yeah, sure. So stent distortions are a reality we can't run away from. And your point is well taken.
The longitudinal foreshortening of the stent is also important, especially in left main when you have going for a very accurate stent. When you overexpand it, the longitudinal length will come down because if it is a trough to peak design in some of the stents which now not available.
Yeah, but
so that is now that
the additional connectors have resolved some of those issues, and here he had kept away from the ostium. So, and he made sure that his guide catheter was not. And I guess he's not using a problem which we have in our country is use a lot of Oxford hardware. What's happening to the guide tip? What's your guide tip? Yeah.
Sir, that radial strength point, as you said, as you overexpand, sir mentioned that the radial strength is likely to increase. That really lends itself to logic, but I want to know whether this data has been shown in vitro data.
Down. You know, there is a Young's modulus of elasticity which would actually work, and the geometry change needs to be completely documented.
No, what balloon was this?
Has it been done in vitro?
No, don't give me Apollo. Give me NC Trek or give me Euphora. Yeah. So the problem is these balloons are extremely high profile and they end up not moving. I really don't like to struggle with balloons within these stents. We're going to choose a different balloon now. And don't give me NC, give me normal balloons. Yeah.
Balloon is still not tracking it.
So he is not happy with he doesn't want to create an LSD or something by pushing his balloon. So
Kirti, just do
that was an Apollo, and I don't like Apollo balloons for this. So I'm going to use a Trek.
No,
give me a Trek.
I'll give you a tip for the same balloon.
Sure.
Yeah, what is your tip?
No, if he wants to take the same balloon, if he's taking new, then I will.
You can tell us. Is it a trade secret?
Who was that? Who was that?
You should give the tip for the other.
For the other people, for the less privileged.
No, but who was that? Who
we all know that. We all have our own tricks. Everybody, we've been inflating balloons and guides, remodeling, reshaping them, and getting them across. But let him do what he's comfortable doing.
I'm very cross with the guy who doesn't want to give me the tip.
Vijay. Huh?
You see, start with a smaller one. There is some dent there. Start with a smaller gun, get some way, and then things will move.
The stent has been, it's a 3.5 stent which has already been opened. I mean,
I agree what you're saying, but
it's an NY balloon.
No,
so
listen. There is some dent there.
He will
which is
resolve
not
it.
le-
He
I
doesn't
think
want.
it's a simple thing.
He doesn't want to push, which I think is very acceptable,
the
because a
small
lot of
one will
people
go.
raised an issue of LSD, and I think it's a very practical
So
thing.
in that issue, you should not have the tug.
See, when you have a better
So you have a
balloon, you
smaller
don't have to
balloon,
struggle.
it will
Yeah, go on.
track and
Two,
track.
Okay, let's see what he does now.
4, 5, 6, 7, 8.
Okay, can we see the
10,
picture?
11,
Kirti, we are looking
12,
at you.
13, 14.
Can you show the angio? Yeah.
Yeah. So
Please
he's got it
don't
across.
I don't want me. Just point on the angios, yeah. Down. Just reduce the cranial, please. Go cranial less. I want to see the edge of the stent. Yeah. Go up. 2, 3, 4, 5, 6, 7, 8. Down. Just give me an IVIS, please.
3 NC.
This is a 3 NC?
This is a 3 NC?
Yeah, 3M.
Not NC. He's taken a.
I somehow I don't use NC balloons anymore.
Yeah. So this is another issue which, how many people are still using a lot of non-compliant balloons? Well, large majority. Even for a pot or a repot, are you still using a non-compliant balloon, or you believe in using a semi-compliant balloon? So there is a small minority which believes in using a semi-compliant balloon, but everybody here still believes in using a non-compliant balloon.
Can I ask Kirti, your edge of the stent is deployed at less than optimal pressure, that means less than 2.5.
Yeah.
And we have not so far
So
expanded.
he is going to image, right? So
Yeah.
then he may re-optimize it.
Yeah. I'm not done with the case yet. Yeah.
Okay.
Okay.
Down.
So I think it's okay to be gentle. You don't want to. I don't know, Nikhil. Do you have any suggestions for me?
Vijay is getting little antsy because he thinks you're going to run out of time. So yeah.
Oh, Vijay, sorry about that. I mean, you can go offline and
No.
take me offline,
We
but I still will take
enjoying
my
this,
time,
so we don't want to go offline. We'll fight with Vijay.
Yeah.
Don't worry.
Unfortunately, I am a little slower than most others, but
thank you.
So the only thing I would like to convey to many of the younger generation of cardiologists is this Kirti is doing a great demonstration of a step-by-step technique, and will actually show you what happens at low pressures and perhaps what happens at the real pressures that you would deploy it.
look at that. See, that stent merges with the distal lumen, and that is what I want. I do not want to traumatize the distal edge.
But we can't see the
I just saw it, but we'll show it to you again. But Dr. Hirohata, please make comments while it's going on.
I'll just make a comment and then you can carry on. What he was doing was making sure he didn't have distal dissections, and therefore that was deployed at optimal pressures.
Yeah.
But clearly in your labs, 14 atmospheres, 8 at 10 atmospheres is truly not adequate. I mean, it's normal for me in 95% of the patients to go to 20 atmospheres in these calcified lesions and up to 25 atmospheres with the non-compliant balloons. Because once you're optimally sized, you actually need to expand these and get the maximum lumen. So it's not just apposition, it's getting the maximum lumen in these calcified vessels. I would image after I've done an optimization in the way I think it should be done, rather than a stepwise, which is great for today's teaching.
Okay, this is the IVAS pullback.
And look at that left main. I think it's 4.0 and it's good.
Yeah.
I think I would expand a little more at a higher pressure in the LED, the proximal LED.
Right.
And that's what I would do. But
okay.
I think, would you do anything more for the distal edge of the stent?
No.
No, I wouldn't do anything for the distal edge of the stent.
Can you repeat that?
Can we see the distal IVUS?
Yeah, so this from the beginning. Yeah, this is a distal reference. Vessel diameter is about 2.2 or 2.5.
Can I have the trio balloon again?
Yeah, almost no plaque here. And probably you can see the stent edge around here.
Yeah.
There's no dissection, and actually it seems to be a very good landing zone of the distal stent edge.
What is the size at the distal edge of the stent?
What is the
lumen area?
It was around 2.6 around there, and we have landed it at 8 to 10 atmospheres, which brings it to its total expansion in a normal artery. There was no plaque there, and only thing the proximal mid-segment needs a little further expansion.
Kirti, everybody wants to know what is the distal CSA, if somebody can just tell us.
The MSA?
Yeah.
Let's do the edge MSA. Distal edge MSA.
MSA distal edge.
Can I have the trio balloon, please? Again.
Balloon, okay.
Just give me the balloon, the same stretch balloon, yeah.
Okay.
I never do that.
Around there. So check.
Oh, so you know.
Check the stent size.
No, it was 2.5. It was 2.5.
Yeah.
2.5. Angiographically from here, it did appear to be 27528, but they got an IVUS which is 2.5.
So that's one of the things, you know, and you know, when we go blindly and assume that all arteries can take a bigger stent, we can get into trouble with these calcified arteries.
Sure. You can have distal dissections which you'll be chasing for the rest of the day.
Yeah.
Yes.
So can you see the IVUS image? This is the minimum lumen area around the distal stent edge, about 4.73 millimeters square. So it's less than 5.5, but according to this vessel diameter, I think it should be enough for this patient.
To 16.
Because the original vessel
would you
size
still accept it because it's less than 5.5?
Yeah, even
18,
if that, even if
20.
the less than 5.5, this stent area should be very acceptable because of the very small original vessel size.
Go up.
What is the size of the balloon you are using now?
The trio, but we are going to 18 to 20 atmospheres.
Yeah, I'm going to proximal. I think the most, a little bit more issue of this IVUS is the proximal part of the LAD. So you can see some under-expansion area for the proximal LAD to the bifurcation of left main coronary artery. So in this case, I think there were more additional balloon dilatation from proximal LAD to the distal left main will be mandatory.
Yeah.
Because we want to get a lot more bigger stent area around the proximal LAD to distal left main.
That overlapping area, do you want to dilate again, or you are leaving it like that?
I didn't see anything under dilated or under expanded in that area, which.
Yeah.
Oh, the floor. Oh, this is not. Wait, hold on. I pressed the wrong pedal. I think, give me a spider, please.
So would you like to check the circumflex now, or the circumflex physiology? Are you happy with seeing what, because angiographically it looked very good even on the cranial view. We'll see the caudal now.
I wouldn't do it in my lab, but if anybody wants to kind of interrogate, now's the time.
Yeah. So how many people want the circumflex to be interrogated? We have a small minority here, less than 10%.
We'd be happy to do it. We have an FFR wire, and we'd be very happy to just do the ostium. Just the ostium, right?
Yeah. Ostium looked good, but we'll get the functional significance once you go into the circumflex. You will know, because most likely whatever little you were getting on the FFR initially was coming because of the left main lesion.
I mean, you know, at home I wouldn't do it, but I'll do it because I'm in a meeting. Arya Caudal.
No, he's just going to buy.
Go, Arya, slide.
I would just like you, Kirti and Dr. Hirohata,
to
comment, because this left main stent, for everybody's understanding, is very important, including my understanding of these IVUS findings. I interpret these IVUS findings as an under-expanded stent. Maybe I'm wrong, but I would not be accepting this in my lab and I may want to be better educated.
Which
so
part
how
of
don't we have a discussion
which
on this
why don't which part of the left main you think is underexpanded?
Okay, going to.
Can you do a left main MSA?
Yep.
Remember that the distal, and I can even visually see it from here.
So
and
he's
graphically-
talking about the bifurcation point,
That's right.
which
Yeah, this one,
angiographically
this one
does
right
not
here.
appear very pretty.
So polygon of confluence has not been actually treated appropriately.
No,
You
no.
know, you expect the and
The POC
only the proximal end of the stent seems opposed in the left
Yeah.
main,
Yep.
but the rest of it is clearly underexpanded. I would not be hesitant to say that I would be worried.
Yeah, after this IBUS, he made another dilatation for the left, distal left main to proximal LAD. So this IBUS image immediately before the second post dilation. And of course, well, around this is the left main, minimum lumen area is about 11.78. So of course, comparing the original vested size, you can go up a little bit more. For example, the 4.5 millimeter balloon dilatation will be acceptable. But this area is not so bad. But in my feeling, in my lab, probably I will go up a little bit more, a little bit higher pressure for 4.0, maybe nearly the 20 atmosphere or something like that. And of course, proximal LAD seemed to be a little bit underexpanded. But
So
he made another
Dr.
dilatation.
Hirata, after the last IVUS, what was the stent area at the level of the left main bifurcation?
Left main bifurcation. Okay, so
Just do all the MSAs. Yeah.
Yeah.
left main bifurcation.
Balance it out, zero it, equalize.
I have one more doubt. Actually, we
So
can see
going
in
back
the 10 o'clock, 11 o'clock position
Yeah,
in the
yeah,
left main.
and yes, around
there's
there.
under
Okay,
position
okay.
of the stand. Can we leave that
Yeah,
if
okay,
the
okay.
MLA is fine?
Yeah.
Can you see in the left main
So
at
Kirti,
10
Yeah,
o'clock,
this is
11
the
o'clock,
this is the
significant under
bifurcation of
position
left
the
main.
stand.
So now checking the stents,
Where?
minimum stent size.
Wait, hold on. Let me have a look at it.
Kirti, we have to wind up the session because we are running short of time. So, what
Please.
is the FFR value into the circumflex? Can you?
We're just about to balance it. We balance it, equalize it. Yeah, okay, great. In a minute, I can give you that in a minute.
8.16
that we
is
have
the
to
stent
stop
area
and go
of
to the session.
bifurcation.
Come on, get me that. We can do a full run for you. Adenosine, please. Yeah. You can record the baseline. That's okay. Record.
Or
Yes,
you can
please.
do an RFR just now. if
No,
that's
we're doing
okay.
an adenosine, proper adenosine. In 60 seconds, you'll know the answer. Baseline 0.94.
He wants 60 seconds. Yeah.
60 seconds.
You know, to answer earlier Ashok Seth's question, I think I was pretty happy with they're around 8 in the LAD, which was, I assumed it was a 3.5, so 9.6, so we've got 8.2 as an MSA. And when you look at the confluence, it is more than 10, and when we come down, it's around 11. I think one of the reasons not to overexpand this artery is because the lesion is very eccentric, and if you start overexpanding these arteries, I risk a little bit of rupture. I mean, if you try to start expanding these calcified lesions eccentrically higher, we might even compromise our existing results. 0.91 in the circumflex.
Great job. So let's give them a big hand, and thank you very much for a great demonstration.
Thank you. Thank you.